Thank you very much. I'm Catherine. I'm the GP lead for Coordinate My Care. Can I just see a show of hands of who knows about Coordinate My Care in the room? Okay, excellent. So it's an electronic end-of-life care record, and if we could just sort of start off, Anita mentioned about people that we've potentially lost, our family or loved ones that we've lost. Can I just have a show of hands who has been involved with someone's care who's died, who's been one of our loved ones? So quite a lot of you. And out of those, how many of those actually died in their, do you know, if they died in their preferred place of where they wanted to die? So that's probably about 20% of people who put their hands up. And so on that basis, Coordinate My Care is one of the electronic registers that was sort of based on one of those formatting ideas. From the Department of Health Strategy, so you'll know, it was around coordination of care, the main part of identifying who was actually in their last year of life. How do you access and get access to their medical history and records? And out of that it also came that registers, locality registers, would be a good place to start of actually coordinating people's care. There were 8 national Department of Health pilots, and in London there were 2 main pilots from Camden and Islington and Sutton and Merton, which was run by the Royal Marsden and which is where Coordinate My Care is hosted today. This is alongside the NHS London rollout of 111. So as NHS London's 111 is being rolled out by April 2013, Coordinate My Care is coming CCG by CCG alongside 111 implementation. So the 2 main pilots were about 800,000. Richmond and Twickenham, so I'm a Millen GP, and Richmond CCG GP, so I'm cancer and end-of-life care lead there, and also run alongside the long-term conditions for there. We joined as an independent partner with them around sort of when they were first starting. The pilot then extended to just under 3 million, and then when this goes across London by April 2013, it will be obviously the 7.7 million. The main leads, I think it's really important, although it says Catherine lead, the main lead is actually Julia Riley, who's from the Royal Marsden Hospital, and then there's also Chi Chung, who's the Camden Islington lead as well. The key part, the bit that's not been done before, is actually the link between all of our services. So there are obviously the community teams, there are hospice teams, acute teams, but it's the London Ambulance Service that are key. So for instance, in Richmond, just out of our care home admissions to hospital, in Richmond we spent £500,000 just on ambulance service calls in the last year. I mean, this is huge. That's just from our ambulance service, and that was only 1/3 of the admissions that we actually had. So from a commissioning aspect, this is important, but from a patient care aspect, the bit that's missing when carers panic and when there are out-of-hour services that just don't know about patients, that's the bit that's been joined up that hasn't actually been done before. So you've got everywhere around London that is actually linked by these key services. So when an ambulance person actually arrives with patients, they already know this is their Coordinate My Care record. These are the really crucial bits of information that they won't have previously been able to have. Nowadays, with the fragmentation of general practice, there aren't GPs that you can access 24/7. It is very much sort of their working hours or district nursing working hours that then go on to out-of-hour GPs and night nursing services. So now this is with the ability to be able to join all of those services up. And there's a nice little diagram to show that that's how we're joining up. It's really important to say that it's a whole system wraparound. So this is based on people. It's based on our interactive skills of being able to coordinate all of that care together, because what we realised is actually if we're not all talking together, you have these beautiful pockets of knowledge about patients that are actually just either within a hospice or perhaps on a GP database, within the community nursing notes, or sometimes with the patient's handheld records. But that's typically where it's lost out previously. So by joining it all up together, you're actually very much able to communicate with each person that's relevant at the right place at the right time and having the right conversations to then be documented again to share with other people. So I'm also the London GP lead for the Finding Your 1% campaign. And so the Dying Matters Coalition, we've realised, actually, if you don't identify the right people, we don't stand a chance in hell of actually getting the right information and then going on to record those. So the key message from that part is actually helping. How do we help all of our colleagues find who those right people are? So 20 patients per GP per year will be in the last year of life, and we've got to start knowing who are those patients. Previously, we know that that's not been done very well. So with the National After Death Audit, we showed that roughly only a quarter of people that were in their last year of life were actually identified. So this is with things like our GSF practice meetings and our actual register that we've got already. We then go on to say it's about looking at nursing home patients because, for instance, in Richmond, 45% of those are actually dying within 6 months of being admitted. So it's looking on a wider basis, how do we know who to actually input? It's not just cancer, so we're now sort of going from our community roots to say we need to think of absolutely everybody, so it's all of the prognostic indicator guidance. And this is, I know for everybody in this room, we probably know, but actually a lot of GPs, they haven't been party to this before. A lot of community nurses, it is something that's new that we're able to help them identify patients. So as part of Coordinate My Care, who knows about the Lothian SPIC tool? Okay, so this is the based with Scott and Kirsty Boyd and Scott Murray from Lothian. They basically developed this brilliant tool, and also there's Patrick McDade who's done the London tool, which is a quick guide for identifying patients for supportive and palliative care, who's here today, and that's also on the End of Life Care website as well. So both of these tools are basically aimed at how to find your 1%. For instance, so this will say, so are you in bed for sort of 50% of the day? And what's your performance status? Are you in a nursing home will be another. So you've got to find two of the general clinical indicators of deteriorating health. And then you look at your advanced disease status. So have you got COPD? Are you having recurrent admissions with it? Are you on home oxygen? Are you sort of a later grading of it? So you pick who your patient is, perhaps with multiple comorbidities, and then you ask, would it be a surprise if they died in the next 12 months? And if the answer is yes, then very quickly we know that we should be putting these patients on to Coordinate My Care register. So once we've found the 1%, it's about having, Anita was saying, the difficult conversations. We may make it difficult, but I mean, for me, as a GP, I never even got taught about palliative care. I fell into it by accident to then go and work in a hospice. But in medical school, we were never taught about it. And the majority of people in medical practice, apart from the juniors that are coming on now, it's the same. We weren't really sort of taught a lot of these skills. So it's how to have those difficult conversations. And Coordinate My Care, alongside the template training, will go round with specialists that are training all of the community services on how to have those conversations as well as using the template. It's a verbal consent that you then can record on the register. If they don't have capacity, you can record in a patient's best interest, and then a patient is always offered a copy of the notes. So far, it's roughly about 5% of patients at the end of being consented actually say that they would like a copy of Coordinate My Care. And also you can update it at this is the brilliant part. Previously, you might have had notes on your record in a GP practice, or you might have had your handheld notes, but how often were they actually updated? With this, a patient can change their mind and it will be immediately updated to all of the relevant people involved. And actually, very important, this is based on St Christopher's Advanced Care Plan, who alongside Joe Hockney from St Christopher's have actually done a huge amount with care homes as well. So this really is based on a sort of principle of excellence that we go on to. Who knows about 111 in the room? Okay, excellent, more hands. So again, this is the first time. So previously, having worked in a GP out of hours, if I'd had a cancer patient that had severe pain and they've called in, I would normally be having to tell them, I'm so sorry, that's about a 6-hour wait because you're not actually urgent. This isn't a life-threatening emergency, so you don't get our 1, possibly they might get a 2-hour wait from a GP visit if necessary, but normally it's a 6-hour. With this, it's the first time that actually the 111 call handlers actually directly, if the record is on, if the patient's details are on Coordinate My Care, go directly to a 111 clinician. If the actual symptom is on Coordinate My Care, you can very quickly from there diagnose whether they need to go to be seen by a GP, to be seen by the night nursing service, or whichever, or social care, whichever part they will actually need. If it's an urgent symptom, then they will be immediately directed onto 999, and if it's not, then there's no difference and it actually goes back to NHS pathways. It's important to note, though, that before it actually goes on to Coordinate My Care, they can immediately, if they get pain, breathlessness or bleeding, they'll immediately be directed to the 999 service, and there's no loss there because they will have the notes of Coordinate My Care in the ambulance service for when they arrive at the actual patient. So, an example of basically a patient with lung cancer arrives at a hospital, new diagnosis, and then is actually put on to Coordinate My Care. An immediate system of email alerts goes back to the GP to say this patient has been diagnosed with lung cancer, is very poorly and will be actually coming home. This can then help the GP identify that this patient needs to be reviewed, and any documentation will then be updated to the GP. The GP can then go make a visit if they want to, or they can call just to touch base. That part is left with them, but then they can base that care when they come back into the community. A few weeks later, if a person becomes unwell, or whatever time they actually become unwell, the key parts of when people panic are carers panicking and locums that may not know the actual that may not know the patient, or out-of-hours services that may not know what the patient's wishes have been previously. Those are the key times that we know that actually then ambulance services are called. But now when the ambulance service is called, they actually have all of that record, so they can immediately say to both family and patient, did you know this person's on Coordinate My Care? Do you know that these are some of their wishes? Can we actually orientate at this time, at this place, with this person, what they actually would like, based on what they've said previously? This can then come on to getting community nurses to know what their medications are, and then also going on to have syringe drivers set up in the community, or whatever actually is needed at the time. But ultimately, the patient can die, if they want to, at home, in their surroundings, if that's what they want to have. So it's very much not that these patients have to die at home, it's around what the patient wants at the right time in the right way. So from a commissioning aspect, this is where it gets really exciting, because in the light blue, we can show that over the last sort of year or so, the figures are exponentially going up as we're joining locality by locality. The purple figures at the bottom are basically monthly figures that are being added each month, and this is getting more and more. So currently we've got 5 localities that are building their numbers. And we've probably got about, so that was February, we've got probably about 1,600 now, so they're continuing to increase. It's really not just for cancer. So knowing that only a roughly quarter of people die from cancer, it's really important that we're capturing people with frailty, with dementia, who previously have had a poor level of care. Actually, this is enabling them to actually have those conversations early. And the earlier we have them, especially for patients that will lose capacity, the better as part of an advanced care plan. So roughly sort of 46% are cancer diagnoses, and the rest are non-cancer diagnoses, compared to previously where sort of 80–90% on practice registers were patients with cancer. This is fantastic. We've really engaged with the majority of community services at the moment. So we've got the majority of GP practices being trained alongside community nursing. There's more and more input to actually for hospital staff to be trained, and then also all the hospices are being trained. There are slight difficulties because this takes an N3 connectivity, so it's relying on hospices actually having N3 connectivity, but we're working on that. And in terms of where people are actually dying on Coordinate My Care, so this is the huge part. Over 60% of patients are actually dying in a care home or in their own home. And like a smaller, much smaller, 24% actually dying in hospital when they're actually on Coordinate My Care. the huge part is actually if they have their preferred place of death recorded on Coordinate My Care, 73% of those patients are actually dying in their preferred place of care, in their preferred place of death. From a commissioning aspect, so as well as patients actually achieving their choice, we, in the last sort of 300, 400 odd patients from November 2010 to November 2011, we've had roughly about 400 patients on there. Those patients have only had just over 100 emergency admissions. So if we base it on what we know, roughly between 2 to 3 emergency admissions for end-of-life care patients, we've managed to reduce those by a good sort of 300, which equates to, I think, sort of between 750 and 1.2 million savings, and that will increase if we're actually managing to capture and identify correctly and then capture the 1% for us in our population.